Hello, this is Dr. Lauterbach, and this is the mini lecture for week 3. We will cover 2 chapters in the textbook, chapters 4 and then chapter 5. Chapter 4 covers 3 general areas. First, they go through 10 theories and discuss them. Then they talk about searching for evidence using different databases and also how to evaluate the strength of the various pieces of literature that you may come across. They go through it pretty quickly, the various theories, and you may feel a little overwhelmed about which theories and to what extent do you need to know them. So I want to just point out to you the ones I think are the most important for you in practice and for use in this course. The health belief model focuses on individuals' beliefs about their susceptibility to a health condition, the perceived severity of the condition, the perceived benefits, and barriers to taking action. Social cognitive theory emphasizes the role of observational learning, self-efficacy, and social influences in behavior change. It also highlights the reciprocal interactions between individuals and their social environment. Trans-theoretical model, also known as the stages of change model, describes behavior change as a process that occurs in stages, including pre-contemplation, contemplation, preparation, action, and maintenance. The planned behavior explores the influence of an individual's attitudes, subjective norms, and perceived behavioral control on their intentions and subsequent behavior. Social ecological model recognizes that health behaviors are shaped by multiple levels of influence, including individual, interpersonal, organizational, community, and social factors. The social ecological model recognizes that health behaviors are shaped by multiple levels of influence, including individual, interpersonal, organizational, community, and societal factors. And the diffusion of innovations theory investigates the spread and adoption of new ideas, innovations, or behaviors within a population, emphasizing the role of communication channels, opinion leaders, and social norms. Well, I want you to read all of the models that are presented by the authors. I want you to focus on these and have an understanding of their key concepts and how they're used in achieving health promotion in groups and individuals. I'm going to walk you through the key points of the models presented in the textbook, which will be more than the ones you see here, but include these, and also show you the diagrams and how to read those diagrams to understand what they're telling you. Each model is depicted in the textbook in text and then in a figure or a picture of the model. The first model is the health promotion model by Nola Pender. This is not on my list of top models, but it's worth looking at. For one thing, it is one of the very first models that were specifically used regarding health promotional activity. Its major constructs are individual characteristics and experiences, behavior-specific cognitions and affect, and behavioral outcomes. It focuses on health promotion, not just disease prevention. This model was used initially and tested among people trying to stop smoking. So it is associated with smoking cessation, but it can be used for other things as well. And there are other models that are now more commonly used for smoking cessation, but that's what was first published about this model. This is the health promotion model in diagrammatic form. I'm going to take a moment to walk you through how. So one of the things to consider when you're looking at these models is there are constructs and there are concepts. So let me kind of walk through that first. Constructs refer to abstract ideas or variables that are created by the researchers to represent specific phenomena or aspects of their model. Constructs are usually defined based on theoretical assumptions or empirical evidence that are used to measure or describe certain properties or behaviors. They are often operationalized through measurable indicators or variables in that research that can be observed or quantified. Constructs provide a way to represent complex ideas or phenomena in a simplified manner within a particular theoretical framework. Looking at this model, the constructs are across the top, individual characteristics and experiences. The next one is behavior-specific cognitions and affect. And then the third construct is behavioral outcomes. Under each of those, you can see there are multiple factors. On the other hand, concepts are more general and broad in nature. They are fundamental ideas or categories that exist in the real world and are not specific to a particular theoretical model. Concepts represent the basic building blocks of knowledge and understanding that can be used across different disciplines and contexts. Concepts are usually derived from empirical observations or philosophical reasoning and serve as the foundation for constructing theories and models. So to summarize, constructs are specific representations or abstractions of concepts within a theoretical model, while concepts are broader and more general ideas that can be applied across various models and fields of study. Constructs provide a means to operationalize and measure specific aspects of concepts within a theoretical framework. So in this model, Pender identifies these as her constructs. Whereas these that you see down here, prior behavior, personal factors, are concepts. Things that you hear in the real world outside her particular model. She calls these individual characteristics and experiences, but they break down into these concepts, prior related behavior and personal factors. And in her model, she says these individual characteristics and experiences come together under these two concepts: person's prior related behavior and personal factors, which are biological, psychological, and sociocultural. And they then act on behavior-specific cognitions and affect. So that is how things act in the individual. Prior related behavior impacts perceived benefits of action, perceived barriers to action, perceived self-efficacy, and activity-related affect. How do I think or feel when I'm doing something? Personal factors, she breaks into two more concepts: interpersonal influences, those would be family, peer, providers, and then norms, support, and models, and situational things, which are options that they have, demand characteristics, and aesthetics. These two things under this construct then drive a commitment to a plan of action. And that leads to health promoting behavior. However, and that comes under the behavioral outcome, which is the health promoting behavior. These bubbles up here that you see here these are modifying factors. So whenever you see these charts, and you'll see these things off kind of to the side and impacting things, they are a modifying factor. They don't go linearly. They kind of modify how the commitment to action, which will trigger the behavior, might be modified. And so her modifying factors are immediate competing demands, low control, or immediate competing preferences, high control. So the individual has very little control over demands, things that are happening external to them but are driving their ability to act on their commitment to action, and the immediate competing preferences, which are under high control of the individual, the things they prefer to do, and that these also will modify the movement from a commitment to a plan of action to the actual health behavior change. Using this model just to show you how to orient yourself to read these charts, because they're all built in the same way. They always go left to right. There'll be constructs, these kind of columns, if you will, and then the concepts under the construct. The belief model is a very commonly used one. It's used for a lot of things. It is used to understand preventative health behavior and behavior related to illness, symptoms, and disease management. The major concepts are perceived susceptibility to illness and the severity of that illness, and perceived benefits and barriers to taking preventative or treatment actions. A major concept of the health belief model is the perceived barriers to treatment. Self-efficacy is a concept within the social cognitive theory, which you'll see later. So, looking at this, there are modifying variables: perceived seriousness and perceived susceptibility, which then drives the person's belief about their perceived threat, their belief about perceived benefits versus perceived barriers, and they get cues to action. Self-efficacy is not fully developed in this model, but it has to do with, do I think I can actually do what I'm being recommended to do? Do I actually think that what people are telling me, my providers or others, that my behavior is leading me to a threat and I need to change my behavior? Do I believe that? Well, that depends on whether I believe it's a serious problem and if I really believe I'm vulnerable to it. And then, well, I probably have some barriers to doing it, but are the benefits worth it to put in the effort to overcome the barriers? And then something added a little later in the model is they need a cue to action. Something has to trigger it. It could be a life event, it could be new information, it could be a pandemic, it might be any number of things, but there is going to be a cue to action, and that all will result in the likelihood of engaging in a health-promoting behavior. Cognitive theory has major concepts of self-efficacy, knowledge, outcome expectations, goals, and facilitators and impediments. The approach is to build self-efficacy. Social cognitive theory was developed by Albert Bandura from the concept of self-efficacy, the perceived capability to perform behavior needed to produce expected outcomes. It also includes the concepts of knowledge, outcome expectations, goals, facilitators, and impediments. Knowledge of the risks and benefits of the behavior is a precursor to change. Outcome expectations can include physical pleasure or discomfort, social approval or disapproval, and self-satisfaction or self-dissatisfaction. Goals provide a guide for behavior change and contain specific plans and strategies. Facilitators and impediments include socio-structural factors existing in the social, political, and economic and environmental systems. And these are modifying factors. The outcome expectations and the socio-cultural factors modify the movement of building self-efficacy, moving toward your goals, and ultimately getting to the behavior. To build self-efficacy, the most important approach is to help clients check prior behavior consistent with their goals. Even if they can make a small step in the right direction, we use this to help build confidence that they can do this and more again. Seeing others accomplish similar goals can be effective, and this is called vicarious experience or modeling. Verbal persuasion can be effective too, but it is less effective than self-reflection or modeling. The theory of planned behavior was developed by Isaac Azen in the 1980s to explain human social behavior. It extends from the theory of reasoned action, and it posits that behavior change is influenced by the intention to perform the behavior. Intention is a key word here. Here's the model. So we start at the left, background factors. These are all the things that impact an individual. They will lead to behavioral beliefs, normative beliefs, and control beliefs, which then create an attitude about the behavior, a subjective norm or perceived behavioral control, and those lead to intention. Actual behavioral control is an important factor because sometimes people have intentions that they really can't implement for reasons that are both internal and external to them. So that's where actual behavioral control comes in, and when all of this happens, it leads to the desired behavior. The integrated behavioral model is really a hybrid of a couple models. It focuses on individual motivational factors that predict likelihood of performing specific behaviors. It posits the behavior is likely to occur when the person has intention to perform it and the necessary knowledge, skills, perceived control, and self-efficacy. The determinants include behavioral intention and personal agency. In 2002, the Institute of Medicine called for an integration of theoretical models used to develop communication strategies that target health behavioral change. They called for that for the same reason that you're feeling like your head is spinning from all these models. There are tons of them out there, which ones to use. So the Institute of Medicine, IOM, called for the people doing the research to consolidate some models and make something more usable that could become kind of a standard. And this is what they came up with. So Fishman, Asian, and colleagues responded by expanding the TRA and TPP models to incorporate constructs from social cognitive theory, which was specifically self-efficacy and perceived control. The expanded model was called the integrated behavioral model and focused on individual motivational factors that predict the likelihood of performing specific behaviors. According to IBM, behavior is likely to occur when the person has intention to perform it and necessary knowledge and skills, perceived control, and self-efficacy. Similar to the theory of reasoned action and theory of planned behavior, IBM, or the integrated behavior model, proposed that the most important determinant of behavior is intention to perform the behavior. Behavioral intention is determined by three constructs: attitude, perceived norm, and personal agency. First, attitude toward the behavior includes experiential attitude or the person's emotional response to performing the behavior. A strong positive emotional response to performing the behavior increases the likelihood of performing the behavior. Perceived norms reflect social pressures one feels to perform or not to perform a specific behavior. Subjective norms are defined as a belief about what others think one should do. Perceptions about what others actually do, the descriptive norm, may also be a part of the subjective norms. Subjective norms vary across cultures based on the importance of social identity in various cultures. Theory of reasoned action and theory of planned behavior and this integrated model have been used to understand and predict a variety of health behaviors. For example, condom use, immunization, screening for diseases, diet, and physical activity, and more recently, it's been used to look at vaccine hesitancy during the pandemic. So the trans-theoretical model is something most nurses know about from their undergrad. It is also called the stages of change model, and here are the stages of change: pre-contemplation, contemplation, preparation, action, maintenance, and termination. It's all about the willingness to change. In the pre-contemplation, stage, the patient does not intend to change behavior in the foreseeable future. They're actually oblivious to it. In the action stage, specific activities are carried out to make a change. In the preparation stage, the intention to change is planned in the immediate future. In the contemplation stage, the patient has the intention to change. Those are kind of out of order, but let's just walk through it again. Pre-contemplation, oblivious, don't know, don't care, not even thinking about it. Contemplation is now I'm seeing some information or watching others do things that are making me kind of wonder if maybe something should happen. Then there's preparation, where I'm really starting to think about what am I going to do where I think I'm going to make a change in the very near future. Then action is when I actually start to do it. Maintenance are the things that I do to maintain it. And there are trade-offs that you will see in this model. Sometimes people exchange say I'm going to quit smoking. Okay, that's a big change. So first I'm a smoker, I don't even think about it. Then somebody I know gets lung cancer, and now I'm starting to think about it. And then I go get some help to get ready to prepare for stopping smoking. Then I actually start taking Chantix, and I stop buying cigarettes, and I'm really doing it. And then I get into maintenance, where because everybody has under stress and different problems, want to move back to a more familiar comfort zone of smoking in this case. But I'm going to do other things. So maybe what I'm going to do instead of smoking is some other things. Maybe it's something healthy like exercise. If I have cravings in my exercise, that's going to be part of my maintenance strategy. Or maybe it's something not so healthy like, well, I'll revert to vaping. Not a good idea. You get the idea. And then termination, where it really becomes integrated into my whole life. Here's the model. It shows the stages and then the processes used. The TTM processes of change were integrated into over half of the 100 mobile applications available for smoking cessation. That was reported in 2018. TTM was found to be more effective than health belief model for smoking cessation in nurses in Turkey. There are other things you can add to it. In one report published in 2018, hypnosis was helpful in helping people quit smoking while also using TTM. Quiz. So a nurse is caring for a patient who's planning to eliminate high-fat foods from her diet. Which would the nurse identify as occurring when the patient says her intention is to drink more beer instead of eating fat? Would that be dramatic relief, social liberation, reevaluation, or counter-conditioning? Kind of alluded to this in my discussion about smoking, where we said somebody's going to go to vaping or exercise. That's counter-conditioning, and it's part of maintenance. Let me show you. Counter-conditioning right here. Those are the counter-conditioning. It's part of action and maintenance. So the correct answer was D. The two types of change processes within the trans-theoretical model are experiential and behavioral. Within the behavioral responses, substituting alternatives for problem behaviors is termed counter-conditioning. The patient plans to drink more beer instead of eating high-fat foods. Dramatic relief, on the other hand, is an emotional response to behavior. Social liberation is defined as social opportunities that support changing the behavior. And self-reevaluation is examining oneself with and without the behavior. Moving on to the patient activation and empowerment model, it's defined as an individual's knowledge, skill, and confidence for maintaining his or her own health and health care. It is associated with positive outcomes. Patient engagement is a broader concept that includes activation, interventions designed to increase activation in the patient's resulting behavior. Here is the graphic depiction of that model. Patient activation is defined as an individual's knowledge, skill, and confidence for managing his or her own health and health care. Experiencing success leads to positive emotion and further success, so clinicians are urged to ask people to do what they can to accomplish a goal and then build on that success with more complex action. Patient activation is associated with most health behaviors, better health outcomes, reduced hospital admissions, and reduced costs because people feel more in control. Patient engagement is a broader concept that includes activation, the interventions designed to increase activation, and the patient's resulting behavior, such as obtaining preventive care or engaging in regular physical exercise. The diffusion of innovation model was developed outside healthcare, but it can be used in healthcare. And its concepts are developed to enhance communication from innovation development to integration. 4 elements: innovation, communication channels, time, and the social system. The stages of the diffusion innovation model are knowledge, persuasion, decision, implementation, and confirmation. Here you see it in a figure. So DIM was developed in the 60s to enhance communication from innovation development to integration. That was before it actually was applied to healthcare, but it can be used in health promotion. The model is comprised of the 4 elements that we've already talked about: innovation, communication channels, time, social system. The innovation is a new idea, practice, or object that is diffused or communicated through certain channels over time. A place where we used this model actually wasn't necessarily in a health promotion, but when we were bringing electronic health records into hospitals, which happened in the 70s, 80s, and 90s, depending on where you are over time, there were innovators bringing them in early, sometimes as early as the 80s, late 70s. Small pockets of electronic health records are starting to appear from largely major research organizations. And then there were early adopters, and then an early majority, because now we're getting up to 50%, and then the late majority, and then the laggards, until finally, somewhere along about this point here in the laggards, CMS came in with quality measures that required the use of electronic health records and the use of electronic medication administration, and they tied it to payment to push people over the edge. Those who were still lagging behind, and there weren't a lot, but hospitals that were still lagging behind using electronic health records were given a boost to push them over the finish line. But DIM can be used for any number of things, and it includes, you could think of it like vaccination, smoking cessation. What's it going to take? And the concept also of importance is you eventually get to a critical mass, and then actually what's happening is, to borrow from another model, there gets to be social pressure, strong social pressure, once you pass that critical mass, to conform to the new way. And the laggards are pretty dug in, and eventually you have to kick them in the pants, and that's basically what CMS did with their financial incentive to adopt electronic health records. The social ecological model is pretty straightforward. It can be used in different ways in health promotion. It focuses on the interaction between the individual and the environment. There are 5 levels of influence: intrapersonal, within the person; interpersonal, between persons; institutional, community, and public factors. So now we're starting to move into the models that aren't so much related to individual clients, but more at the level of public policy. So SEM was developed based on the concept of an ecosystem, and it focused on the interaction between the individual and the environment. Building on this, SEM includes 5 levels of influence, and we just discussed those, and examining where populations are at risk can help to develop interventions where they are most needed in the context of the other levels of influence. One thing the text, an example right from the text: nursing eating habits in acute care, meaning while nurses were at work, were examined in a qualitative study using this model, which showed that nurses' perceived ability to take breaks was due to the following factors: patient load, the unpredictability of patient needs, reluctance to burden other nurses while they're away eating, a tendency to prioritize patient care over self-care. No surprising, as we socialize nurses from the beginning of their first study, whatever that would be, say BSN undergrad, ADN, whatever, wherever you started. We've been socializing you to subordinate your own needs to the needs of your patients, and the repercussions of working longer hours to complete work, staying late. Maybe your boss is mad at you if I take a break. Maybe you're just tired. You want to get out of there. You'd rather just go home. You're not going to take time to eat while you're at work. Those of us who've done the work, makes perfect sense. But that's how you would apply this model to that situation. So other influential factors included the presence of unhealthy food options, regulations restricting nurses' ability to eat and drink in the workplace, and the need for more staff. All makes sense. The precede-proceed model is a group model. It's for understanding where a community is when you're trying to do community-wide, statewide, national kind of projects. We're going to walk through it very quickly. It's may be interesting to you for use in your group projects, but it is way bigger than anything you could ever really hope to fully implement in the confines of an assignment in this course. But let's just kind of walk through it. So there are 8 phases. Phase 1 through 4 is called precede. Phase 5 to 8 is called proceed. So here's the model. Start over here with me. Here we are at phase 1, social assessment. Then we go to phase 2, which is an epidemiological, behavioral, and environmental assessment. More assessment, educational and ecological, and then intervention alignment. So you understand the environment and you get to interventional alignment. That takes you down here to administrative and policy assessment. So you understand kind of what's going on in the community, and then what are the bureaucratic issues that may be faced. And then you start over here in implementation. So as we're making the bend and we're heading now this way, the arrows are going this way, we enter phase 5. Okay, it's a little hard to read this. So phase 5 is implementation, and then phase 6 is this stuff here, process evaluation, and then phase 7 is impact and outcome evaluation. They also give you these little bullets to like input, process, output, short-term impact, longer-term impact, short-term social impact, and long-term social impact. It's a complex model, but it works when you're doing major community or national or large-scale programs where you're trying to really affect a change in behavior. Now we leave the models and we go to the part of the chapter where they're talking about finding and evaluating evidence. And then in chapter 5, it follows with how you implement evidence. I'm going to just hit on a few points here. First of all, PICO questions. All right. So evidence tables and a brief report. You're going to have a discussion of evidence. There are going to be strengths and limitations of the body of the evidence, important client differences to consider, areas where further research is needed, recommendations for practice, considerations for applying the evidence, and interprofessional health implications. What's all that mean? A PICO question you're going to start with is simply a search strategy, and we're going to talk a little more about PICO in the next segment, chapter 5. You're going to build an evidence table. You're going to look at a ton of stuff. You're going to narrow it down. You're going to then say, this is the kinds of things I'm interested in. And the PICO question, if it's done well, will drive you to the stuff you care about and not a lot of other things. And then you're going to put it in a table to help you actually write a brief report where you will discuss the evidence, the strengths and limitations, important client differences that you have to consider. And that important client differences you have to consider is a very essential part of evidence-based practice. matching the knowledge, the science to the client. That's a big component of evidence-based practice. You also would have other things. In this group project, you're going to do a lit review. I'm not really looking for you to do a whole lot of discussion about strengths and limitations of the body of evidence and that sort of thing. It would be good to mention, is this appropriate to the clients that we're talking about, and recommendations for practice. That goes in the narrative, like, here's what we found, these are the trends, blah, blah, blah. And you might reflect on any of these in your narrative report component of your lit review. Authors don't highlight this table or this hierarchy very much, so I'm going to just spend a minute on it. This is the levels of evidence from the Joanna Briggs Institute, a research institute, which is quasi-governmental. In any event, it's just a hierarchy of what is the strongest evidence to what is the weakest evidence, and they assign all these different categories to it. Let me just kind of pick one. Experimental designs, completely randomized samples, a tight control group, match control group, where you control the control group, you control the intervention group, and you randomize people. That is an experimental design, also known as a randomly controlled trial, or RCT. Highest standard of quality of evidence. And the lowest is somebody's opinion, okay? They mention like bench. What is bench research? Well, bench research is kind of the preclinical stuff. The things that are done in the laboratory under controlled conditions, but they aren't in a whole organism. You know, they might be just a cellular activity or animal models or things of that nature. They're used in the development of things, but you can't really apply that to your patients because there's other things that need to happen in the meantime. We found out something works in certain types of cancer. Well, we don't just say, oh, let's start injecting people with this, right? You got to go through animal models, and then you're going to go through a lot of different trials, and you're going to have some ultimately randomly controlled trials and that sort of thing before you're going to have evidence that is reliable enough that you're going to use it with patients. That's just an example, but this is kind of, you're going to see this over and over again. I'm not going to go through every kind of case study. If you're in the DNP curriculum, you're going to see this in your research course, you're going to see this in your epidemiology course, you're going to see a lot of this stuff. But this is a standard used across the world for rating the level of evidence. The other thing I would tell you is, when we talk about the power of the evidence or the value of the evidence or the quality of the evidence, what we're really saying is, how generalizable is this evidence? Can we say, based on the research, that we have a high level of confidence that every time we do it, it's going to get the same outcome, no matter what kind of population, what kind of person, what kind of social situation, it's always going to be the same. If that is high, then we have high quality. It's highly generalizable. If it seems to be, I don't know, it's really kind of depends on who they are and what sex they are and what this and what that, then we don't have that same level of evidence that whatever the intervention is really going to work. Okay, let's just wrap it up quick here with a little bit about evidence-based health promotion. I want to give you a disclaimer. This is not a course in evidence-based practice. So when you come through this part of your curriculum, you are not getting a comprehensive piece of knowledge. You're not gaining a competence about evidence-based practice. But we do talk about evidence-based health promotion. There are models for evidence-based practice in nursing, which you will, if you haven't already learned them, you're going to learn them. But I'm not teaching it in this course. We're just focusing on health promotion, just so you know. So it is important to build your health promotional interventions with substantial evidence, and necessary to consider diverse consumer expectations and values when applying evidence to practice. All right, appraisal of the evidence. You just saw the Joanna Barnes Institute hierarchy, so you know that's there. Let's talk a bit about PICO, because some people think mistakenly that PICO is an evidence-based practice model. It is not. PICO is simply a search strategy. P is for population. It refers to a specific group of individuals or patients being studied. This includes characteristics such as age, gender, medical condition, or any other relevant demographic factor. I is intervention or issue of interest. It represents the treatment, intervention, exposure, meaning environmental exposure, or issue being investigated. It could involve a drug, therapy, procedure, diagnostic test, or any other healthcare intervention. C is comparison. This component specifies the alternative or control treatment that will be compared with the intervention. It helps to determine the effectiveness or superiority of the intervention over the comparison group. O is the outcome. It identifies the specific outcome or endpoint that is being measured or evaluated. This could be a clinical outcome, patient satisfaction, mortality rate, quality of life, or any other relevant measure. T is sometimes not even used, but when it is used, it's time frame. It refers to the specific time period over which the outcome will be measured or evaluated. This component helps to define the temporal aspect of the research question. By breaking down the research question into these components, the PICO framework helps to focus the inquiry, define the relevant population, intervention, outcomes, and facilitate the search for evidence in the literature. It also helps in determining the study design and guiding the selection of appropriate research methods. The use of a reference librarian is promoted when searching literature. That is in your text. I highly endorse this recommendation. You have a reference librarian at your disposal through the Madonna University Library. There is a reference librarian designated for the College of Nursing, and all you have to do is call the library, which you can find, or contact them through an email, which you can find in the portal, and you just can't believe how much better your search is going to be if you solicit the help of a reference librarian. The authors point out it's important to examine the fit, cost, and feasibility. So you keep the major findings of the best quality studies in mind, and then you think about which evidence-based recommendations you will make for a client, understanding the client. Then you create a list of resources for the client, and then you discuss the feasibility of the recommendations with the client when you meet with them. When you're dealing in organizational work, you've got to think about support and resources. If you're trying to influence your organization to take on a health promotional activity, you're going to have to build some support, and you're going to do that by gathering the most up-to-date resources, the state of the science, to back up your claims of why this is a good thing to do. And then you're going to figure out, who do I need to get to? Who do I need to talk to learn more about how this would fit in the organization or not, so that modifications can be made. But more importantly, people who have the power to make the change happen by making money available or access to places or talking to people, there are going to be gatekeepers you need to get to make it happen. So in implementing evidence-based practice for an important client health promotional issue, it is important to build on initial success. So we're going to start maybe with a pilot and try it and see if it works, make changes, and then take it broader. So try it in your practice setting, maybe then in the area, and then broader to the community. There's a whole thing in the book where they talk about using information systems to help you with your search and that sort of thing. You don't need to, I'm never going to test you on this stuff, but if you didn't know, there are these things. Wrong button, hold on. These things here. I use EndNote when I write. These are just proprietary. They're not cheap. They cost quite a bit of money. They may be available through the university at a discount to you. You'd have to check with the library to know. But you search through them, And then they build a little data bank so that when you're writing, you can just put the cursor where you need to put an in-text citation. You put the cursor there and you click on what it is the study you want, and it will automatically do all the formatting for you, put the in-text citation in, and start building your reference list. It's very cool. So promoting healthy policies is addressed changes in overall health policies, larger impact in less time, less cost than individual and family-based health promotional efforts. When you come out, you just have a broader reach. It works over more people, so you get total change at a broader scale. They mentioned LEAD. I'll just tell you a little bit about that. It's about locate the evidence, evaluate the evidence, and assemble the evidence, and then inform decisions. Key questions are: why is it important that we consider this issue? What should be done? And how do we implement this for our particular client group? Evidence-based health promotion includes appraisal of evidence, examining the fit, cost, and feasibility of implementing an evidence-based practice change, and gaining support and resources for a necessary practice change. Then using information systems in assessment and evaluation is also important, and it's going to come up later again in Chapter 13. As well as working with individual clients and families, we may best help everyone improve their health by advocating for healthy institutional and public policies. Whether our audience is peers, an interprofessional team, and our practice-setting policymakers or consumers, it is important to understand the perspectives of those we are working with to present the evidence with the most impact. And that's it.